Joao Victor, most of you all know Joao Victor, the postdoc working with us at Gemini. He's going to be presenting on some work on our PPK intervention in Tanzania and the relation between our this alcohol intervention and mental health outcomes. So without further ado, I should also, okay, a little further ado. This presentation is going to the Kettle Brewing Society, a conference coming up that specializes in all things alcohol related. So if you have some constructive feedback, we can improve the paper, the presentation for that conference coming up. Okay, that's the rest. That's the end of the ado. So I'll turn it over to Joel. Lovely.
Thank you. Let me share. All right. It should be showing up okay, right?
Yes.
Yep.
Okay. Nice. Thanks. All right. Folks, before I start, I just want to give a minor heads up that I don't know if this presentation is going to be a poster or a oral presentation. They haven't released that yet, so I just assembled slides and I'll transform this to poster later if needed. But the conference is coming up in early June. It's going to be in Glasgow, and like Ashley was saying, it's the Kettle Brewing Society conference that researches alcohol and alcohol use overall. All right. So good morning, everyone. My name is João Vitor. I'm going to be presenting today our work entitled "The Prevalence of Depression and its Association with Alcohol Use Behaviors and Consequences," a community survey from Moshi, Tanzania. And you can see down here the list of authors for this. I want to say abstract, but we also submitted the full paper draft. So this manuscript, I'm going to say. First, no conflicts of interest to declare. And to get us started and set up in the same level, alcohol use is a major concern globally, with nearly 2.3 billion people using alcohol in the world, making it basically one of the most used psychoactive substances. The use of alcohol is correlated with injury, disabilities, chronic illnesses, and many others. And for Tanzania specifically, it ranks among the top three African countries in alcohol consumption, even though Africa itself is not the highest region with the alcohol consumption. It's growing a lot, and Tanzania stands out in that setting, being the top three. Unfortunately, there is a correlation or connection with mental health, with substance use. And specifically for mental health, there is a connection between also with injury, self-harm, and in this both in our in the setting of the study, which is Tanzania, but also globally. The use of substances and specifically alcohol is related with like a coping mechanism as well. It is correlated with exacerbated mental health conditions. Unfortunately, in low and middle income countries like Tanzania, mental health substance use services are usually either fragmented or not available for everyone in every place, but also or totally absent overall, leaving many people undiagnosed or unsupported. In that sense, the objective of our study was to explore the association of alcohol use and depression in the northern Tanzania or the Kilimanjaro region, more specifically in Moshi, in the northern Tanzania region. For our methods, this was a cross-sectional survey that was done in the Kilimanjaro Christian Medical Center in Moshi, Tanzania. You can see here a figure showing the ED and the location, the approximate location of Moshi in the map in Tanzania highlighted in blue. And KCMC is a major zonal referral hospital in the northern region. Our participants were enrolled by a convenience sampling, and the inclusion criteria was that they needed to be residents in Moshi They needed to be adults, so 18 years of age or more. They needed to be fluent in Swahili, and they needed to be living in East Africa for at least 5 years. Patients were consented, and data was collected using RedCap. We applied, we collected demographic data, but also we used some different tools, either to measure their mental health status, like the patient health questionnaire, but also their substance use behavior, like using the alcohol use disorder identification test or audit, the drinker inventory of consequences, the drink, and some other information like health-related quality of life, etc., using the SF8. In our study, we define depression as having a PHQ-9 score bigger or equal than 9, which is validated for Tanzania context. And similarly, we use the audit scores above or equal to 8 to define alcohol use disorder. We perform descriptive analysis with frequencies and for categoric variables and medians and interquartile ranges for continuous variables. And then we inspected the association of depression and alcohol use behavior using univariable and multivariable logistic regression. And analysis were performed using R. So for our results, our population were mostly male with 54% of participants. They were mostly Christian, mostly employed, and had an average in a median of 10 years of education. From the total 400 participants that were enrolled, 385 were included in the final analysis after excluding a few patients that did not respond to the mental health questionnaire, so the PHQ-9. And the median age was 34 years, and the most common tribe for participants that they belonged to was Chaga. In terms for our major variables, like dependence and independent variables, we had a depression rate of about 16% in our population, and the PHQ-9 had a distribution at a median of 4, ranging from 2 to 7. 56% of our participants reported consuming alcohol in the last 12 months, with 13% of them report being classified as in alcohol use disorder. As I told you, alcohol use disorder is classified using the audit above or equal to 8. From our sample as well, about 33% reported having at least 3 or more drinking days in the past 2 weeks. And you can see here the distribution for the other ranges. So between either 0 days, 0 to 1, or 1 to 2 days. And the drink score had a median of 1. In terms of the association, we saw that there was an impact on a correlation between the audit score and depression. So I try to put this in a sentence in which each point in audit increases the 4% higher odds of depression, which is shown here in our odds ratio. And more specifically, if we stratify this sample of patients for participants with severe AUD, in essence, those with audit above 14, they had more than twice the odds of having depression compared to those that had lower audit scores. And then for the alcohol consequences measured with the drink score, we also see that at each point increase in drink had a 3% higher odds of depression in this population. And all of these results are already considering they are controlling for age, sex, tribe, years of education, and employment. In conclusion, we report a significant association between alcohol use disorder or alcohol consequences with depression in our sample. We believe that screening for depression and alcohol use disorder should be applied for patients that are complaining about either manifestation, because we can see how they can frequently co-occur. And this highlights the needs for developing culturally appropriate interventions that address both conditions simultaneously. Of course, this is an initial analysis, and further research is needed to explore the causal pathways between the substance use, alcohol use, and depression, and of course, to evaluate interventions that could treat both conditions at the same time. That's what I had for today. Thank you all for listening, and I'm open for questions.
Thanks, Rob. Feel free to put in the chat or you can unmute to share any comments or questions for Joao.
Great job.
Thank you.
I'll start us out. Joao, great job. The beginning part of where you're launching us into the story of why this matters, you did excellent on that. And I say that from someone who doesn't know a whole lot about the alcohol stuff. So good job on making it for people like me. I wonder in the results, when you're talking about depression, like the odds being 2 times or 4 times, I wonder if there's a way where you can quantify that to let us know how bad that is. Is that a doubling of symptoms, or there might not be a way to do that, but that was what I was asking about the odds ratios. But other than that, I thought
Yeah,
it was good. Yeah.
yeah. Now that I look of it, even having like the standard forest plot with those odds ratios could be good for people to visualize because that's the standard way of representing that. Yeah, but
Well, or
not really sure.
even if a 2 to 4 times odds ratio means they have 2 more days of depressive symptoms per week.
Mm,
So I just wonder what that means clinically.
yeah. I'll also open the question for our clinical folks in the group if you wanna jump in.
Can you bring up the slides, Roberto?
Sure. Give me a second. Where is?
Yeah, it might be hard to explain because if it's in terms of the number, the score of PHQ-9,
I
I can see
believe
that
this
being
is
a
the
little
one you are
tricky.
alluding to, right, Emily?
Um, well, there's the 2. Where's the 4 odds ratio?
I don't think we had the
There's a
four. I think
4% higher.
4%. Yeah, it should be 5%
Oh,
actually.
there's the 4 that I was thinking of. Yeah, this
Yeah.
slide.
So maybe I'll do a better job at describing how this is like a binary cut. Like using PHQ-9, the cutoff would be, of course, bigger than 9 to bigger or equal to 9 to classify the person as in depression, because one of the variables is continuous and the other one is a binary. So I guess this 4% is kind of hard to understand there. But essentially, what I'm trying to say with this is that the more you have in audit, so the more alcohol use you have, or closer to alcohol use disorder, the more likely you have to have your be to have depression. But then when we binarize and classify this into severe, which is above 14, that's where we get the bigger association here, the bigger correlation, which is
Oh,
2.4. So when you start on the severe AUD risk, that's where you have higher odds.
got it.
Given my ignorance here, what you defined as alcohol consequences here would be like domestic violence, would be what? What would be it?
The consequences here is measured by the drink score. So the drink is a questionnaire, like a survey with like about 50 questions or so. And for each, I want to say for each domain of consequence, so you have social consequences, you have interpersonal, intrapersonal, you have a few items and try to measure those consequences. But it all sums up to a single score. And we basically use that as a continuous range usually to measure the consequences,
Thank you.
of course.
Joao Victor, I'm gonna highlight what Dr. Florida brought up in the chat, which is who were the KCMC community. Let's talk about that a little bit more.
Yeah,
Because your study objective says the KCMC community, but then your study setting talks about the hospital.
Yeah, can you
yeah.
show the criteria again.
Yeah,
So
I'll be extending this, but essentially we approach the participants using a convenience sample. So a few of those patients would be either family members from patients attending to KCMC or people that were around KCMC, but not necessarily. So we extended this to the population in Moshi, but
what
mostly those around KCMC.
what was the data source? Which data set were you using?
It's the PRACT community sample.
Okay, okay.
Maybe
Oh,
the
Yeah,
confusion
because I
was
thought it
that
was the needs
Ashley alluded
assessment
to the
one.
the
No.
PHQ-9, the trial. This
Okay.
is not the trial. This is prior to the trial.
that
Yes.
So
makes a
I
lot more
would
sense.
describe this a little bit more because I think that the community really does make a difference in terms of how you're describing it. There's many people
Hmm.
who don't come to the hospital or come in outside of their local community. We
Yeah.
are truly talking about the KCMC community, not the KCMC distribution with a representative sampling of the community. But those, we collected a convenience sampling of people in town and at the hospital, patients or non-patients, to be able to validate scores and are using this data set.
Yeah. And also I wanna bring in the moment of the presentation, if I have time, a few more maybe discussion points on this.
Yep.
Because comparing our rates to what we have reporting under settings in Tanzania, et cetera, I just wanted to be within the 10 minutes. I think that the format that KBS has is that they have like a panel that will discuss and then ask questions afterwards. So I feel like we're gonna have more time to go on about the details after the presentation as well.
So, João, another important point here is the concepts defined by the scales. So I would refrain from using the word depression or
Mm,
depressive patients. That's not a diagnostic as much as a screening. So I think you should probably use depressive symptoms or a positive PHQ-9 score or something like that, because
mm,
it's not the same analogy to a clinically diagnosed depressive patient. Same
okay,
thing for the alcohol disorder. We've always had this back and forth that we call audit above 8 as a patient with an alcohol disorder, and that's not true. As much as it's a
okay,
patient with or alcohol, harmful alcohol use. That's what concept refers to.
okay. So I'm adding the comments here. Thank you, Joel.
Then I would like to explore, please comment. Some substance to that number, what percent increase means, and that's more likely going to be a difference in number of people than necessarily. I don't think it's going to be days or symptoms because you're making it binary, but we can try to give it some some level of patient related impact.
Yeah, like for example, this isn't on the outcome side, but on the input side, Joao Vitor, the point on that one slide that says about for each increase point in the drink, I'd have to look back at it
Oh,
specifically, but
sure.
that that might well, no, I mean I'd have to look back at the drink
Oh,
itself, but I think what that would correspond with, but we need to confirm, is that um, for each additional drink consequence, this is the outcome. But doing it in the alcohol in the depression side or PHQ-9 side is more what Joa's getting at. But even the inputs you could do it that way as well.
okay.
Cool. Cool. Well, congratulations on the presentation, João. Congratulations, Tima, and the team for getting the paper to this level. I know it's been a long time putting this analysis together, but it's it looks neat when you see it presented this way. So great job getting it here, Timoth, João, and folks that worked on this analysis.
Thank you.
Awesome.